talk about treatment approach for obesity. So, dear friends, obesity is a chronic relapsing metabolic disease basically caused by adiposity. And we all know that obesity is yet not being recognized as chronic disease in India. Still, we tend to say that a obese person is a healthy person. So this is the myth, and more we get ourselves informed about the metabolic abnormalities which are associated with obesity, and then feasibility of treatment of obesity, we will be able to address this problem in a better way. So, good morning, ladies. Ladies, yeah, ladies and gentlemen. Uh, Thank you very much for being here. This is a sponsored lecture by Eli Lilly, and these are my disclosures. So, when we have to treat a patient or a person living with obesity, there are some goals which we have to understand. The first and foremost thing is that the person should stop gaining weight, number one. Then, number two, we have to reduce the weight. And for that, we need to have some target weight. What is the weight we want to achieve? And once we are able to reach the target weight, we will try to prevent the weight gain. So, stabilize that. So, there have been studies which suggest that even a short term reduction helps in metabolic benefits. So, the best way when we talk to a patient about what should be the weight loss we should be targeting, we should make a long term goal as per their height and metabolic health, and then short term goal. And you let them know, then only you can follow them. So, short term goal, I would say for 3 months or 6 months, we should keep 5 to 10%. A reasonable weight of 0.5 kg per week is what I try to give my patients. And then long term weight, say in 1 year, what weight I want to achieve. The fact is that once you level the diagnosis of obesity, patient becomes receptive towards management. They try to adhere not only to medical treatment but also to lifestyle intervention. Prior to my talk, Dr. Ajay Tiwari was uh, talking about beneficial effect, how Tirzepatide, a, a drug which was supposed to treat diabetes, has wonderful effects on weight. The other way around, treating weight has got wonderful effects. 2 to 5% weight loss improves glycemic measures. 5 to 10% weight loss improves mobility, HDL, urinary incontinence, sexual function, and reduces healthcare cost. And 10 to 15% or greater weight loss leads to improvement in steatohepatitis, sleep apnea, and reduces mortality. When you talk about remission in diabetes, probably the sweet point is 10 to 15% of weight loss. And once you classify a person that he has got obesity, you will see that responsiveness to the management and lifestyle intervention improves. So, dear friends, if I do have a person living with obesity, how should I approach? Lifestyle intervention is first and universal management strategy which should stay throughout, right from BMI of 25 to 40. And for Indian patients, I would say overweight starts from BMI of 23. So anybody more than 23 should start having lifestyle interventions. And lifestyle interventions include dietary modifications and exercise. When you talk about pharmacotherapy, BMI more than 27 with any adiposity related complication can be selected for pharmacotherapy. So what are those adiposity related medical complications? Hypertension, diabetes, dyslipidemia, fatty liver disease. So BMI more than 27 with any of the adiposity related complications, you can start medical therapy. Of course, higher BMI 30, 35 and 40, you have to go for that. Surgery, bariatric surgery or metabolic surgery do have wonderful effect. When should it be started? For BMI more than 30, where lifestyle intervention and medical therapy is not giving adequate response and the patient has got adiposity related medical problem. For BMI more than 35, in addition to medical therapy, you can give surgical treatment option if adiposity related complications are there. And for BMI more than 40, even in absence of adiposity related complication or whatever is the response with medical therapy, surgical therapy should be advocated. So dear friends, let us first talk about lifestyle intervention for obesity. So this was a very good lifestyle intervention program called Diabetes Prevention Program, which constituted essentially of two components. One was diet, which included hypocaloric diet and physical activity, which included at least 60 minutes of physical activity or per day or 30 minutes of activity per week. And in this study, a target weight loss of 7% was considered through these two modifications. And what the results were? Those who are able to achieve 7% or more weight loss had 58% reduction in incidence rate of diabetes. Over longer follow-up, even in comparison with metformin, where metformin led to prevention in diabetes of 18% over 10 years, people who followed this diabetes prevention program lifestyle changes, prevention in diabetes was more than 30%. So lifestyle intervention was more effective in preventing diabetes in comparison to metformin. Now there is another aspect of lifestyle intervention. Lifestyle intervention can produce meaningful weight loss over short term, but unfortunate part is weight regain is common. So this is from 2001 to 2006 enhanced data with more than 2,500 patients, and they did show that 40% people lost their weight by more than 5%, 20% lost their weight by more than 10%. However, weight regain on long term was common. Within 2 years, more than 50% of the weight loss was regained, and within 5 years, more than 80% of the weight loss was regained. So that is the limitation of weight loss being done by just lifestyle intervention. Here comes pharmacological therapy for obesity management. It has been discussed in detail by my friend Dr. Ajay Tiwari. If you have to consider a patient for pharmacotherapy, first thing that is it starts is which patient should be considered, and I have already elucidated what is the criteria for them. And then we need to discuss patient about the beneficial effect of weight loss. I have got a good number of patients who are on pharmacotherapy, and what I'm going to talk to you is how I do talk to them and why they do accept it and why they do continue it. Unless you inform the patient and unless you have informed decision and unless you let them know what are the deliverables from that therapy, they will not accept it. So you have to talk to them. What is the target which you want to achieve in 1 year? What is the target which you wish to reach in 6 months? What is the target which you wish to reach in 3 months? And then you need to talk what are the beneficial effects are there of weight loss in terms of metabolic profile, in terms of other comorbidities. Then you need to find out if patient is able to achieve the drug, there is no contraindications, and then start the medication. We need to assess the efficacy and safety of that drug every 3 to 6 months. And once treatment goal is met, we should continue medication. And if treatment goal is not met, we need to substitute or increase the dose or add the drug for achieving the target. Now, pharmacotherapies which are approved for weight loss in India include three: Tirzepatide, semaglutide, and orlistat. Starting dose of Tirzepatide is 2.5 milligram once weekly. Then it has to be up titrated by 2.5 milligram every 4 weeks till you start getting meaningful weight loss. Semaglutide doses 0.25 milligram, it has to be gradually increased, and orlistat has to be 120 milligram thrice daily. After medical therapy comes the bariatric surgery. So there are recommendations from bariatric surgery. Metabolic bariatric surgery is recommended for people with BMI more than 35, regardless of presence or absence or severity of obesity-related comorbidities. The options for metabolic surgeries include adjustable gastric band, vertical sleeve gastrectomy, Roxanne gastric bypass surgery, biliopancreatic diversion, biliopancreatic diversion with duodenal switch. Let me tell you, dear friends, bariatric surgery is a very efficacious method, and laparoscopy Roxanne gastric bypass is the gold standard due to its excellent weight loss and comorbidity resolution. However, easy to do is laparoscopic sleeve gastrectomy, and that is what it is being done most commonly in India at present. Some comparison of results that we do get from metabolic bariatric surgery. You can see clearly the winner is Roxanne gastric bypass with total weight loss around 30%, resolution of hypertension in around 40%, resolution of type 2 diabetes in 40%, resolution of sleep apnea in 50%, with minimal serious side effects and mortality rate. With this background, I would like to share my experience of using Tirzepatide in initial 4 months. These are the data. Actually, we started in around 75 patients in first 4 months, April, May, June, and July. And up to 31st October, we collected the data. Out of those 75, 45 patients completed 3 months of Tirzepatide, and we have that data. So this is under publication, we have already sent it for that. So early real world impact of Tirzepatide on weight, glycemic control, liver fibrosis surrogate, medication requirement in Indian adults with obesity. So basically these were the patient. So these are the baseline characteristics. You can see this reflects relatively young, predominantly middle age Indian obesity cohort with female preponderance, and baseline weight was 94 kg. What you can see from the uh, stratification of obesity, uh, all all patients included are obese with more than 95% having severe obesity, BMI more than 30, This is severely obese, high risk Indian phenotype, almost all in obesity class 2 and above. As far as comorbidities are concerned, 75% of them had diabetes. So, obesity with or without diabetes. 25% didn't have obesity, diabetes. And these are the results which we did have in 3 months. At 3 months, there was a significant improvement in anthropometric and metabolic parameters. Average weight loss of 6.3 kg, BMI 2.39, waist circumference decreased by 9.8, HbA1c decreased by 4.49. See, the baseline HbA1c itself is very low because most of these patients were not treated for diabetes, but most of these patients are being treated for obesity. We do have another study where we have registered around 250 patients, that is also under publication, that is by our whole group, and there we have got HbA1c reduction of 1.9%. Since my talk was on obesity, so I have included only obesity data. So in that 250 patient, we have 75 patient who has completed 3 months of Tirzepatide, and there within 3 months we have seen HbA1c reduction in the range of 1.9%. So that is the efficacy of Tirzepatide on diabetic parameters. Here, since baseline HbA1c itself is 6.87, so HbA1c reduction still it is significant, 0.004. Random blood sugar, systolic blood pressure, they have decreased significantly. Beneficial impact on cholesterol, HDL cholesterol have been found, so favorable atherogenic profile shift has been given. Now comes side effect. Most of the studies say side effect is in 60 or 70% surpass trial or so. But in our observation, we did see 95% of the patient did complain of GI side effects, some or the other, indigestion, dyspepsia, nausea. And we can understand this is actually the way or the mode of action of the drug, and that is why it was common. So side effect was almost exclusively GI side effect. We have done safety monitoring, no signals in liver, kidney, or any other parameters were seen. As far as weight loss is concerned, within 3 months, almost 50% of patient, rather 52% of the patient achieved weight loss more than 5%. 20% achieved weight loss more than 10%. So that is huge. Half achieved clinically meaningful more than 5% weight loss, 20% achieved more than 10% weight loss. And if you stratify them on based on the BMIs, this beneficial effect was seen across all BMI. So those patients with BMI more than 35 do not have reduced response. Response was all across whole BMI. Those with BMI more than 40% also achieved more than 10% weight loss in 20% cases. Weight loss benefit was uniform across BMI classes. And thus, we had defined the summary or the conclusion of this observation study. Mean weight loss of 6.3 kg, waist reduced by 9.8 kg, HbA1c 0.49. Improvement was consistent across all comorbidities. 20% weight loss was achieved in more than 10%. 20% achieved more than 10% weight loss. 31.5, that is total 52% achieved more than 5%. No baseline factor predicted higher response. FIB4 improved in intermediate and high risk categories. So in this real world Indian cohort, Tirzepatide demonstrated early improvement in weight, glycemia, metabolic therapy burden, independent of baseline characteristics. We are doing longer follow-up of these patients. They are in our cohort, and we will be publishing longer follow-up data also in future. So dear friends, at the end I would like to summarize. Obesity management involves permission, assessment, advice, goal setting, and support. BMI and complications guide treatment via lifestyle modification or surgery. Lifestyle changes alone often lead to weight regain. Various pharmacological surgical options exist with varying outcomes. Treatment goal should be set with the patient and reassessed regularly. Thank you very much for your patient hearing. I will be happy to take up any questions if there are. Thank you, boss.
Thank you. Thank you, Chandra sir, for